Okay, our last speaker in this session on plasticity is Marina Pérez.
Thank you. Hi, everyone. I'm Marina. I am a PhD student at the University of Zaragoza in Spain, and I'm going to present some of the work I did last year as part of a research stay at the University of Texas at Austin about phenotypic plasticity in glioblastoma. So there have been already a few talks about glioblastoma in this presentation, so I will just briefly introduce it. It's the most common and lethal brain cancer. Here are some figures to bring you some context. Although it's not the most common tumor, it still affects quite a few people every year, and it has a really bad prognosis with less than 7% of patients making it more than 5 years since diagnosis, and a median survival of roughly 14 months, which is less than a year and a half. So this would be the typical course for a patient. This is what it would look like at diagnosis. This is the tumor. After surgery, we can more or less remove the most of the tumor. After radiotherapy, it seems that everything's going well, but unfortunately, about 10 months after diagnosis, we can see how the tumor has recurred. And this is similar for almost every patient, to the point that we say that recurrence is almost inevitable. And one of the main reasons behind this failure of the current treatments we have is the heterogeneity that is present in glioblastoma. We have intertumor heterogeneity. That means that not two patients with this disease will have the same kind of tumor, and hence they will not respond in the same way to treatment. But we also have intratumor heterogeneity. That means that within the same tumor we can find very distinct areas or structures. Indeed, inside of a tumor, we not only find tumor cells, but a wide variety of other types of cells, blood vessels, chemical substances, which form the tumor microenvironment, which has also been discussed. And a particularly important agent of this tumor microenvironment for glioblastoma is oxygen. So the relationship between cells and oxygen in glioblastoma can very simplifiedly be described as cells around blood vessels which provide oxygen, and they can grow around these vessels until they eventually provoke the occlusion of the vessel, so the oxygen flow stops, and some cells are going to die around the vessels, forming a very characteristic structure of glioblastoma, which are necrotic cores, and the surviving cells are going to try to escape, forming traveling waves until they reach eventually another blood vessel and the process is restarted. So the challenge we face when modeling this tumor evolution is to take into account both kinds of heterogeneity. So for the first one, it's really important that we do patient-specific models to take into account the individual response of each patient or tumor to the different stimuli or treatment. And to take into account intratumor heterogeneity, it's important that we do spatially resolved models in which we can somehow reproduce these structures. So this is the overview of my talk or my work. I'm going to present two mathematical models, and it is the same model but with some variations, and try to fit them to a data set of in vivo data in rats with gliomas, and try to calibrate and predict tumor evolution. The goal here is to find if there's one of the models that performs better than the other one, and what insights can we get about that. So first, I'm going to briefly explain the dataset, which was generated at the University of Texas by David Hormuth some years ago in a previously published work. And basically, we had a cohort of rats which were injected glioma cells and imaged through different days. We have around 7 imaging points for each rat, although some of them have less, but that's more or less. And from the different modalities of MRI that were performed, we were able, or they were able, to obtain estimates of tumor cellularity and vasculature throughout the different time points. So moving to the mathematical modeling, we are going to use as starting point a previously published model also, in which we describe through PDEs the evolution of tumor and vasculature fields. So we have diffusion terms, which are a bit more complex than the traditional diffusion because there are cross terms accounting for both vasculature and tumor space. And then the diffusion coefficients are mechanically coupled to the substrate to account for the constraints that can occur in diffusion when stresses appear in the tumor. We consider that the tissue is a linear elastic solid. And also we consider that the current capacity is affected by both tumor and vasculature. Then we have growth terms, which are logistic terms, only that in the perfusion equation we have a non-locality that accounts for the distance to the tumor center, so that vasculature angiogenesis occurs in the periphery of the tumor instead of in the center. And we have finally death terms. Cells die when they don't have enough oxygen or when there is not enough vasculature, and vasculature dies or disappears, preferably in the center of the tumor. So these are in red the parameters of the model, and the one we are going to focus most here is the growth rate, because there are different ways of treating each parameter, and in this case, the growth rate. We can calibrate it as a global parameter, but this doesn't take into account any spatial heterogeneity. So we could do local calibration for the parameter, so we would have a different value for its pixel or voxel, but this dramatically increases the complexity of our model or of the parameter space in which we perform the optimization. So what we propose is to introduce heterogeneity in a more biological way, introducing an activation function that says that proliferation depends on oxygen. So the more oxygen or vasculature we have, the more cells are going to be able to proliferate. So this introduces an extra parameter. We are going to compare these two ways in this work, and I named it baseline and perfusion-dependent growth model. So these are the model parameters we have in the baseline model, quite a few, and adding this perfusion-dependent growth activation function, we add an extra parameter. The ones that are shaded in blue are the ones that we are going to calibrate, and the other ones we assume as fixed. So to establish if it's necessary to calibrate all of the parameters, we carried out a global sensitivity analysis following the Morris method, which briefly, it's a sensitivity analysis technique that establishes the importance or the effect of each parameter on a model output by varying the parameters one at a time. And we established 3 quantities of interest to measure somehow the effect of the parameters, which are the tumor burden, which is the total number of cells in the tumor, the total vasculature, and also the tumor area. And these are the results for the model, both models, in which we can see that across all 3 quantities, the parameter with less influence is the vasculature diffusion coefficient, which is colored in dark blue. So we are going to fix this parameter and that way reduce our parametric space for optimization. So this model was implemented in Phoenix and calibrated using a least squares algorithm, and we left the 2 last points of each RAT for validation, so we only calibrated with the rest of the data. And well, I'm going to show you some results. These are the experimental cellularity maps for each RAT at the end day. These are the results we obtained with the baseline model, and these are the results we obtained with the perfusion-dependent growth model. So for some RATs, you might notice that the results are fairly similar. Indeed, I can highlight that in these RATs, we didn't really see any advantage of using the slightly more complex models, but there are some other RATs in which we can see some differences which are interesting. For example, RATs 1 or 5 present kind of a necrotic core with the perfusion-dependent growth model, which wasn't observed with the baseline model. So this model indeed helps us recover some interesting features that are characteristic of the tumor biology. And I want to highlight again that, for example, for this rat, with the baseline model, we just have one parameter for the growth rate, that is all the cells there are growing at exactly the same rate, whereas with the second model, we recover spatial heterogeneity in growth. So only with one extra parameter, we are able to see some map of proliferation, so local proliferation. This is just the complete time course for one of the rats, in which we, again, the lower part is the vasculature and the upper part is the tumor cellularity, and we can see, again, the baseline model and the perfusion-dependent growth model, which better reproduce the final size and shape of the tumor. To more quantitatively assess which of these models is performing better, we followed a model selection approach in which we computed the Bayesian information criterion, which briefly has a term that accounts for the goodness of fit of the model, and another term which is a penalty, which takes into account the number of parameters. So it favors, this term, the models with less parameters, trying to search the most parsimonious model. So we can compute this for all the rats and see that the lower, I didn't say that, but the lower this value is, the better the model is. So we can see that it depends. For some rats, it is justified to add one extra parameter, and for some others not. But on average, the gain we obtained in the BIC supports the use of the perfusion-dependent growth model. Just to finish, I'm going to show some global metrics, which are the CCC, the concordance correlation coefficient, for the three quantities of interest. These are the results for the baseline model, considering all the calibration points. And then we can see that the perfusion-dependent growth model improves this metric for, globally for all the rats. And it also happens when we add the points used for prediction. So in conclusion, it's important to take into account heterogeneity when modeling glioblastoma or every tumor, but in particular for GBM, it's a defining feature. And in this work, we have developed a patient-specific model informed by MRI data, in which we included a vasculature growth activation function, which allowed us to incorporate heterogeneity, avoiding local calibration and adding only one parameter. And the use of this model was supported for our cohort of data by model selection criteria, and was able, importantly, to reproduce some biological features such as necrotic core formation, which weren't observed in the baseline model. So I would like to thank the people involved in this group, in this work, both at the University of Zaragoza and at the University of Texas in Austin, and to thank you all for your attention.
Very nice talk. I was curious about two aspects. One was the physical connection to the proliferation kinetics and other, can you tell me a little bit more about that?
About what?
How does the model affect things like tumor herniation, pressure effects within the tumor? How was that incorporated? Can you just describe that a little bit more?
We are not taking into account explicitly pressure effects apart from the mechanical part, which is a way of somehow preventing tumors to grow very much, because when cells, in the mechanical equation, there's a mass effect of cells. So when cells grow, they somehow create stresses, which at the end of the day decrease the diffusion coefficient, which somehow restrict growth.
Got it. Okay. Yeah, no, okay, very cool. Then the second part of the question had to do with going back to the Hormuth data for the rats. Do you have histology on those? So could you map the perfusion imaging of those animals to the proliferative kinetics spatially and use that to help inform, parametrizing your model a little bit?
Oh, that's interesting. I don't think we have that at the moment, but we have the raw data, so
yeah,
it's really interesting. I will look into that. Thank you.
I was also curious if you thought about any other spatial statistics, like is the shape of the tumor important?
Oh, I haven't really looked into that, but I will look.
Any final questions?
It was just to say thanks, and we're going to wrap things up now. And we'll be back at 4:45, so bye.